Very good afternoon, ma'am and sir. On behalf of our management, PSG and Sons Charities, PSG College of Nursing, I welcome the renowned resource team and dear delegates to Virtual Voices to Vitalize Archives 18. In the Department of Fundamentals of Nursing, we are organizing international webinar on COVID Holocaust today on 20th July to 2021. I welcome Dr. Saravanan, HOD, Professor, PSG Hospitals, Mr. Bhaskar, Modern Matron, NHS Birmingham, England, UK. Dr. Kezi Vino Aram, President, Shanti Ashram, International Center for Fighting Public Health by Scientific Deliberations. I welcome our respectable principal, Dr. Jayasudha, who have been the guidance and support for making this webinar possible. I welcome delegates from various cadres of nursing for the webinar. Thus far, we've got 504 delegates registered from across India and abroad. Dear delegates, kindly keep yourselves in mute mode right through the sessions, except during question and answer sessions. We encourage you to post your queries in the chat box. Feedback link will be posted in the chat box at the end of the session. Without fail, please do send it. Thank you. May I request our principal, Dr. A. Jayasudha, madam, for unveiling the theme.
Thank you, Professor Deena. It's my great pleasure to welcome you all once again. I welcome all our eminent speakers and the delegates who are supporting us throughout our webinars during this pandemic era. This COVID color has rightly named by the Fundamentals Department when we said to choose for the webinar. As we knew that Holocaust, which is really going to have a great effect in destroying the human beings and many things, many people die. So that's the reason which they have chosen it, this COVID pandemic. The rapid and undetected spread of this disease has relatively had high mortality rate from this related to pneumonia, and which has created the current pandemic crisis, which is impacting greatly on the health of the people, the economics, social life on a global scale. This massive medical manpower and resources have been invested in the prevention and treatment of severe pneumonia, increasing the burdens on and even threatening the exhaustion of healthcare system across the world. The coronavirus pandemic has pushed the world into a state of uncertainty. Healthcare people are fighting in this cohesion against the disease whose antecedents and treatment options are yet unknown. The unprecedented nature of this pandemic has prompted its people to take a united stand in tackling this contagion. So as per the SARS-CoV-2, that is COVID-19 testing status as per the ICMR, around 43 crores of 59 lakhs of people, the samples have been tested as of July 18, 2021. And every day, 14 lakhs people have been tested for the COVID test. And Director of Public Health, who said that the Honorable Tamil Nadu Health Minister, Mas Subramaniam, said that more than 1 crore of persons have been inoculated till July 18th. And WHO says that the active cases are per day is around 4,21,665, deaths around 41,000, and discharged or migrated is more than 3 crores. And according to the guidance document for the psychological support for the healthcare workers during this COVID-19 pandemic, which disrupts both personal and professional lives severely, affect the people and societies on several levels. So this distress is not inevitable feeling in such circumstances. During this COVID, it is common for the individuals to feel fearful, stressed, worried, anxious. It's not only the community or the public, even the healthcare people. Such negative emotions can be overwhelming and in an individual. So the crisis ahead with us, another ill effect of this current crisis, where social discrimination and stigmatization. That's what even yesterday we were discussing in the GC meeting, like where our Vice Chancellor expressed that one of the old woman who got discharged and went home, where she found that the people are looking at her in a different way. And nobody wants to come and talk to her. And this really affects this social discrimination. It is not only in the villages, even educated people feel that If they report that they have been positive, immediately the society will not look at them. They will look at it in another way. So this has to be taken off. That's the one thing which we need to take care of it. Social discrimination and stigmatization is becoming more. That should not be there. It has been faced not only by the public, by the healthcare people, as well as their family members. So which may lead into the critical commenting, social avoidance, and emotional distress to many. So restrictions on this normal life, the trade activities and travel, as well as lockdown of cities and countries to prevent the spread of COVID-19 has severely impacted the world economy, threatening an economic depression. So in addition to this financial woes, psychological reactions such as fear of infection, uncertainty, the worry, anxiety, and panic have been reported globally. And during the second wave, where we have lost so many people, most of them are known people for us also. So many have been in a crisis. So our healthcare people have witnessed unrelenting influx of the patients, a high number of deaths, their grieving family members, endless hours of work, helplessness over lack of resources, and mounting fear of contracting the infections to themselves and their family members. So as nurses, we have the knowledge and skills to deliver the care needed in all phases of illness, in reassuring, informing, and supporting the people within the communities who are frightened, worried, and wanting to stay well. So not only the public experiences the psychological crisis, even our own nurses, the healthcare people who are caring the patients with COVID-19. In the beginning, they start with the negative emotions, like a person in the early stage of consisting of they may have fatigue, discomfort, and helplessness due to the high intensity of the work and the fear and anxiety what they have, and their concern for the patients as well as the family members. So slowly they come with the self-coping style, with the psychological and life adjustment, altruistic act, and with the team support they come up, and with the rational cognition. So with that pressure, they serve the people with the increased affection and gratefulness, development of professional responsibility, and the self-reflection. So which may lead in for having a positive emotions with the negative emotions. So during this global pandemic, there is a need to promote calm, build the resilience, and instill hope in the healthcare workers too. That is what is most important. So the whole society must come together. Every country must step up with the public, private, and civic sectors. The movement which demands a coordinated, decisive, and innovative policy action by the people. The fight against this novel disease cannot be won unless we assume shared responsibility. Hence, this appears a bit challenging. Still, our public, when lockdown has been relaxed, everybody we can see on the roads, in the shops, and everywhere. And even they don't follow the COVID appropriate behavior. They don't wear the mask properly. They don't sanitize themselves. They don't maintain the social distancing. So unless we take up this shared responsibility, we cannot fight with this COVID-19 pandemic. So it's in our hands where we need to fight to see this disease which goes off. So I request all the delegates and the eminent speakers for accepting our invitation and to be with us today. And I'm sure the delegates are going to have patience listening throughout this webinar. Thank you all so much. Over to you, Professor Deena.
We welcome Dr. Saravanan T. He's a professor and HOD, General Medicine, PSG Hospitals, Coimbatore. Sir has completed his MBBS and MD Internal Medicine at Coimbatore Medical College and conferred fellowship of the prestigious Indian College of Physicians in 2016. Started his career at PSG IMS Coimbatore as assistant professor in 2002, promoted as associate professor in 2007. Served as junior medical consultant in the Department of Endocrinology, Metabolism and Diabetes at Reefers Hospital, Brunei from August 2008 to June 2011. Currently, he is a professor in HOD Medicine Hospitals, Coimbatore. Dr. is holding additional responsibilities as chairman of the Clinical Audit Committee, member of the Pharmacovigilance Committee, member of the Drug and Therapeutic Committee, member of the Research Committee, and so on. He has written his paper and poster presentations at national and international conferences. So, more than 26 papers at national and international journals, have been the resource speaker at state and international conferences. So we are very pleased to have you to talk about post-COVID. Well, the session is to you.
Thank you, ma'am. Am I audible, madam?
Yes, sir.
Share my screen.
Yes, yes.
Yeah. Really thank the College of Nursing, especially Principal Madam Jayasuda Madam and Leena Madam for considering me to give this talk on the post-COVID or long COVID. I request all the participants to just mute off your microphone as well as switch off your video so it's easy for you to continuously listen to the presentation. Thank you. So basically this topic on the post-COVID or long COVID, yes, introduction speech given by Dr. Seshuda Madam clearly mentioned about the negative aspects of the COVID as it is as an infection and hoping for the positive attitude of ours towards overcoming this infection. But what I'm going to talk about now, maybe 30 minutes or so, the post-COVID or long COVID, to be frank with you all, it is still ill-defined status. That means our understanding of this topic on COVID, the pathophysiology and the consequences, still we are in the learning curve to make us to understand very clearly what we are dealing with, what are the expected events in the near future and late future, how to overcome these late consequences also. So what is my plan is the flow of my presentation would be on the epidemiological aspect of COVID infection. Already Madam has projected in her speech. And I'm also going to highlight on the 4 important aspects of post
வந்தோம் இன்னும் யாரும் இல்ல நான் சொல்லுங்க
Sorry for the technical issues. I request the delegates to stay with us and bear with us. Now we will start with the next session by Mr. Bhaskar Balasubramaniam, Professor Leena. Professor Leena?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
Just 1 minute, ma'am. We will start. Just 1 minute. Very warm good afternoon. I will start with the next Mr. Bhaskar Subramaniam. Sir completed BSc Nursing in the year of 1997, and he's completed a course in mentorship in 2011. He's an aspiring ward manager program in the year of 2014 and 2015, and completed diabetic course. And in 2017, and completed leadership. And about his experience, he started his career as critical care nurse at PSC hospitals in the year between 1998 to 2000. And he has been promoted to be a lecturer at PSC College of Nursing in the year of 2000 to 2001. And he has been appointed as a D-grade nurse at Geriatric Pool NHS Hospital in the year of 2001, and he worked till 2004. Then he has promoted to be as an E-grade nurse at Care of Hospital UK in the year of 2004, and he worked till the year of 2007. And he have been as a charge nurse at Care of Elderly UHB Hospital from 2007 to 2015, and he promoted to be as a ward manager at Care, the same hospital, from the year of 2015 to 2019. Now he has been a modern matron at Ambulatory Care UHB Hospital from 2020 onwards. Currently working as a modern matron at Neurosciences UHB Hospital, England, UK. His expertise in risk management, leadership, diabetic management, training others and presentations, high dependency nursing, neuroscience management, nursing recruitment, change management. Sir, now the platform is yours.
Thank you. You happy for me to share the screen? Yeah?
Yes, sir.
Can you see my presentation?
You can able to see yourself.
You can't see my presentation.
No, it's at the last slide.
Okay. Okay.
Fine. It's fine.
Can you see the first slide?
Yeah, it's fine.
Oh, okay. Okay. Some reason it's I can see the last slide on mine, so yeah. Can you see my first slide? Hello?
Yes, Mr. Bhaskar. Can you put it
Okay.
in a slide view?
Yeah.
Okay. Because I'm not getting, because I couldn't see what I'm sharing, so that's why I'm cut. Good afternoon, everyone. My name is Bhaskaran, and everyone call me Bas here in UK, so it's easier for them to call. They struggle to articulate our names in here. First of all, thank you for inviting me for this presentation to everyone to share what we are going through in UK, and as well as how we prepared ourselves to officially we are calling as a fourth wave of COVID, but because of the fluctuations and everything, but unofficially it's a third wave impact. So I just want to talk through, and if you have any questions, you can always ask me towards the end of the presentation. And I would like to engage to see how things are, and I would really encourage me to ask questions, and it's kind of more of a group discussion as well if you're interested in. And so I'll start with the current situation in UK. So if you look at the numbers on the UK at the moment, so overall we had 5 million cases of COVID, and at present we are number wise is 128,000 people died, sadness because of this disease, and the current death rate is every day is 41, and currently people who are in hospital is 3,964. So you can look at the graph nearby, where it was a peaked on one time where we were getting 60,000 cases during the second wave, and you can see all the way it come down all the way very low, where there was a time there was no patients in the hospital with the COVID, and no patients in the ITU with the COVID. But unfortunately the numbers are rising all over again, and the 90% of current COVID is due to Indian variant called Delta. So that's the one currently it's on the rise in the UK at the moment. So that is causing a massive impact to UK overall. And even though we come out of the lockdown just now, officially we come out of lockdown, and still the government is encouraging people to wear masks on the public spaces and try and maintain social distancing in the if possible. But in the hospital, we still stick to kind of very strict social guidance, and as well as very strict PPE guidance. Okay, so what happened because of the first two impacts? So you can see from the slide, so there are major impact to our NHS. So the things are different when you compare with the India and England. In India, this health service is managed by government hospital, and there is a massive private sector where they manage the majority of the hospital treatment, surgeries, and everything. Here in UK, majority of the services run by National Health Services. We call it NHS hospitals, and very few private hospitals. So most of the health service is managed by the NHS. So that means that the people are put into the waiting list for any major surgeries, or people are waiting for cancer treatment. So because of COVID, we have to stop everything. So the hospitals are first two waves. Most of the wards in the hospital are filled with COVID patients. that lead to cancellation of elective surgery. So we have to cancel all the elective surgery across all the hospitals, and only the surgery is being like if the surgery has to go through, and if we don't operate, either the patient will die. Those are all the patients had the surgery done. Majority of the other operations have been cancelled, and the same thing with the cancer treatment target hasn't been not achieved. So any patients who are identified cancer by the GP and the hospital, they have to follow through the treatment, either chemotherapy or it is any other treatment or a surgical procedure to remove the cancer or tumors. Everything has been delayed because of the COVID impact. And normally the accident and emergency, majority of the patients are come through A&E in our hospitals. So we have each hospital has to maintain 4 hours maximum waiting time for the patient to be seen and reviewed, and if it is appropriate, get admitted into the hospital beds. But during COVID time, there are times where the patients are waiting nearly up to 12 hours in A&E, and once even after patients have been seen and waiting for beds. So the hospital's accident emergencies filled up with the patients waiting for beds, and as well as the ambulances started to queuing up outside the A&E. So they can't leave, we can't bring the patient inside the A&E department. That means we are holding the patients in the ambulances. So it's kind of sometime and all, we used to see 20 ambulances in front of each A&E waiting to offload patients. So these things, what happened, these things lead into staff burnout. Staff are exhausted because of all this workload, and they constantly seeing the patients, and the emotional distress is that's a high impact. And one of them I mentioned is the impact of mental health. The nurses who hasn't seen patients dying in there. There are areas, for example, the nurses in ITU, the nurses in elderly care wards, or nurses in oncology ward, where they have seen the patients regularly, seeing them dying because of either due to the prognosis or due to their condition. But because of the COVID, where we seen patients are, all the wards are converted into COVID wards, where they started to see more patients dying, where the staff are literally kind of couldn't handle that, and this really impacted on their mental health. And because of the first 2 waves, and the lot of staff couldn't handle the NHS pressure and the pressure on the wards, so it lead to so many staff left NHS hospitals as well, because a lot of staff kind of redeployed to ITU. Those nurses felt extreme pressure, where they wanted to take a different option, or they decided to early retirement. So that made a real impact on NHS hospitals. Like I mentioned, this is impact on mental health, and it lead into sickness and low morale between the teams. And the team in the beginning of the COVID, everybody brought together and try and do their best to support the teams across. But the COVID was kind of, now, if we are talking about, is 18 months since started last year, but still hasn't gone away. Now, again, the UK is experiencing another wave. That means now the cases are rising, and now the wards are slowly getting into COVID patients. Again, sickness and low morale is quite high at the moment because of those impacts. So what we learned from COVID? So there are things actually, because of the first 2 impact, we have learned quite a lot of things to see how we can, what are all the things impact. You would have seen, we call it PPE and infection control measures. It should have been the same. It's basically, PPE means it's personal protective equipment, where you need the mask and appropriate gowns or appropriate precautions. Where beginning of the COVID, even sourcing the correct PPE to all the hospital is become real issue. Not only to the whole hospital, the nursing homes where they look after the elderly patients, they also extremely struggle. And for example, when the patients get discharged into community hospital or community nursing homes, they haven't got appropriate PPE. They extremely struggle to manage those patients, that also lead into so many COVID related deaths in the community hospital and as well as the nursing homes. So we learned from how to prevent those things, and as well as the infection control measures, not only the hospitals, and there is a guideline set up by NHS England to see how these patients should be managed in the acute hospital and as well as the patients managed in the community hospital, and when the patients get discharged to nursing home, what they have to follow. So the infection control measures being put under, and as well as guidelines by nationally, so they have a clear information available to everyone at the same time. And the government started to resource the adequate PPE for across all the nursing professionals and as well as all the health professionals. So we are well equipped to look after these patients. And COVID screening and isolation, this is the one really impacted. This is the one caused major issue in the beginning of first 2 weeks. For example, a lot of patients not even though they have symptoms or they didn't test it themselves, or in the beginning of period the symptoms were not clear, so the people not get tested because there are a lot of asymptomatic patients and a lot of asymptomatic people in the public, they didn't test themselves. So what it resulted into, resulted into widespread community spread and as well as the spread in the hospital. And so what we learned from the COVID impact, so anybody coming to the hospital, for whatever the reason they coming in, every patient gets screened for COVID, whether they showing any symptoms for COVID or not. Any patients come to hospital, and the same time any patients get discharged to the community, they also screened before they leave the hospital. At the same time in the nursing home also, the patients been screened 3 times before they get discharged to the nursing home to protect the elderly in the community. And that lead to isolation as well. So the isolation, we were maintained strict isolation for the public, where if either they are positive or they come into contact, they have to isolate for 14 days in the beginning of the first 2 weeks. Recently that is changed into 10 days. And so they have to isolate themselves if they come into contact with anyone, or if they develop symptoms, they have to isolate, and their families has to isolate for 10 days. And in the hospital, this is monitored very closely as well. So any staff, so all the staff, because of this screening process, all the staff been provided with something called lateral flow test. So all the staff have been provided with the lateral flow test. So they have to test it twice a week themselves. And if they are come back positive or anything, they need to report to the hospital, and as well as they take a PCR testing, and then they isolate themselves as well. So it's kind of protecting themselves, their families, and as well as protecting the hospital. So the isolation process is important. That's why we learned from it as well. And the COVID impact to BAME community. So the BAME means, we call it is the Black, Asian, and ethnic minority group. So they are the BAME community. So major workforce of the UK is, like I can go through some numbers, is quite a lot of them is from the Black ethnic minority group. So other than white health professionals, for example, 21% of staff from overall all the workforce in across the whole of health sector is the BAME community. So among the 21%, actually following the COVID, actually 63% of the people who died from COVID, the health workers, 63% of them are from the BAME community. So some reason, we haven't have, the research is ongoing why the BAME communities are highly affected by this COVID. So at the moment, what we have the data is 63% of the BAME community are the one died. So there is a more proportionate to the white healthcare workers, like for example, doctors, nurses, and therapists. So this is more impacting the BAME community. And for example, if you think about the nursing staff, and 20% of the nursing staff in UK come from BAME community, Among overall all the nurses died in the UK, 64% of them are come from the BAME community. Is a similar numbers to the medical staff as well. 44% of medical staff, overall medical sector is BAME, and 95% of doctors are who are died from. So you can see it's a high impact of the nurses and doctors and the other professions come from Black, Asian, and other ethnic minority group. They are well affected because of COVID. And also we learned that we have to focus on staff well-being and as well as the adequate training so we can prepare for the next wave. And also there is, in the beginning of the first two waves, even though the UK is the one of the first country introduced vaccination, like India, UK also had problem with myths around vaccination, especially with the BAME community in the public. They have so many myths and so many beliefs, and it was kind of government and the overall NHS really kind of going back to them, and as well as we bringing them support from the community, kind of encouraging them to take the vaccination as well. So it is really, it is started to change, but it's still a long way to go overall if you look at the vaccination number. So one good thing in view of vaccination, UK is kind of 75% of adult vaccination. Adults are double vaccinated, the remaining are single vaccinated, and the government is pushing for 100%. That's what we are aiming for. Recently, Pfizer has been agreed for the children as well, the age group between 12 to 18. So at the moment, they are identifying who are vulnerable in that age group. So they will be given option to have this vaccination first before it will be given to everybody else. So finally, this is the slide, how we are getting ourselves preparing for the next wave. So during the first two waves, the UK has been changed over. Some of the massive area converted into NHS Nightingale Hospital, we call it. So each major city, so they had a Nightingale Hospital. So London has one, Birmingham had one, Manchester had one. They all have a capacity around 2,000 beds, between 2,000 to 2,500 beds, with the full ventilator, with full oxygen facilities. They all had the vaccination. So they all had the facility ready to go. Recently that been taken down because when the wave come down, we didn't need to use the Nightingale Hospital. So, but that is there in case if we go into third wave again, whether we started to see the same number of patients, if we have to deal with it, we have the choice of opening the NHS Nightingale Hospital to support our work and as well as the capacity. Like I mentioned, vaccination. Now everybody from 18 and years above been offered to all vaccination, and UK has kind of quite few vaccination approved by UK government. For example, Oxford AstraZeneca is been approved, Pfizer is approved, and Moderna is been approved, and there is few more vaccines been on the waiting on the pipeline. So there is quite few vaccinations available for the public. And like I mentioned, that recently the government approved for children's age group between 12 to 16 also can have vaccination. Only the Pfizer has been approved for that one. And the next one is the adequate COVID screening. So, so like I said, the first two impact, we learned our mistake discharging patients inappropriately to the community hospitals and to the nursing home, where they lead to massive amount of death in the community hospital, death into the nursing home, where majority of the elderly patients died in those areas. So we have put in adequate screening available across the whole of the UK. And so anybody has any symptoms, and so they encourage to test themselves and as well as isolate themselves, and until they get results, and they have to isolate themselves. And there's an app introduced, so all the Android and iPhones They all have these apps can be installed. So anybody with the COVID, so the app, if they all have to register themselves into all the adults have to register themselves into the app. So when the app, if anyone got positive, the app, if you have to come into contact with the person, automatically the app will warn you to say you need to isolate. And as well as when the person track and trace the isolation, they also physically ring people to check who are all in the house and monitor them to isolate and provide the advice. I think it's the same similar structure available in India as well, track and trace, and the kind of advising people to do appropriate isolation. And the next one is the really important one. So we have understood, because of the first two waves, the ITU training is really important. So there have been the nurses been prepared, and they all have been, all the majority of the nursing workforce has been identified, and they all gone through adequate ITU training. And we call it for fit testing for the mask as well. So they all go through appropriate fit testing to see the masks are appropriate. So you have the right correct mask and right PPE ready if you've been redeployed to ITU. And during the first two waves, to find out the staff well-being, and there is a nurse who's been, like, not only the nurse, it's also across all the medical professional. I'm talking about only from the nursing side, where there is a role identified. There is a person called nurse advocates, where the nurse has been recruited, where when the nurse is extremely stressed and they've gone through the tough period, at least there is someone they can go to discuss their experience for any support or any advice. So across the hospital, there is a nurse advocate identified, and at least there is a nurses available for them to support. And there is a lot of well-being clinic, and as well as the mental health clinics is been created for the health workers to provide the support to them. And we are also increasing overseas recruitment in view of overall health sector to increase our numbers to support our COVID next wave. And the last one is to identify how the impact happened because of the elective surgeries. We are constantly reviewing what are all the things we can stop. So we constantly prioritize who need to go for emergency surgery. Even if the third wave has been hit us heavily, at least we can still monitor and make sure at the same time, not only the people are dying from COVID, we don't want people dying from emergency surgery. For example, I manage neurosciences. That means neurology wards and as well as neurosurgical wards, where the patients are waiting for cancer neurosurgery, and is a major, for example, things like subarachnoid hemorrhage. So where those patients, if you don't treat them immediately, they will die as well. So it's the kind of same impact as COVID. We have to treat into those who are all emergency surgery. We look at those surgical areas as well. That's the end of my presentation. And any questions?
Video. Yes, Mr. Bhaskar, we have some questions in the chat box. What kind of training program is given there, sir?
1 second, I can just come back to that. Okay, the training program is basically 1 week training program. So is anyway, all the nurses for the skill based, they're all been, most of the nurses in the hospital, they're all trained to do, for example, NG insertion, catheter insertion, and central venous cannula insertion, and monitoring the neuro-ops, and those are all the standard skills being developed across everything. Those are all the normal skills expected from the nurses working in across any sector. The advanced skills is mainly to look after the patients in ITU. For example, training related to ventilators, how to manage, and training related to CPAP and non-invasive ventilations, and how to look after the patients with the tracheostomy and as well as any other altered airways, and how to manage patients with the, for example, if not only they sedated, ventilated, but they have other issues, For example, they will go through the dialysis. So they will be having variety of training to support. If the nurse need to be redeployed to ITU, they should be able to manage it as a holistic care. Is not only they can only look into the nursing side, because some of them, the nurses follow the standard protocol. They don't have to wait for the medical support. They obviously some advice we need to take, but there are things where the nurses can carry on the treatment rather than waiting for the medical support.
Oh, okay. The next one is that can you brief about the community precautions taken so far in UK and any news and laws and policies which are announced?
So the community precautions, like I mentioned, so any patients, for example, from nursing home patients get discharged back to the community, they have to be 72 hours clear of COVID, and as well as we have to do so one negative test, and as well as patient has to be negative on the day of discharge. And the same thing when the patients get admitted into the nursing home, they get tested on the admission as well to make sure they don't show any symptoms, because there are patients who don't have asymptomatic, still they can be potential carriers. So we test them before discharge and we monitor them as well. So in the community, they have the infection control policy. They monitor that one as well. So all the persons get admitted into the nursing homes, for example, they test their patients to see anything. And in the hospital, any of the outbreaks happening, they all get tested all the patients get tested every 72 hours. And the nurses has to do lateral flow test every 2 days a week. But if the outbreak is happening, the nurses also get tested for PCR test once weekly as well. So all these tests to protect patients and as well as to the nurses. And the strict infection control policies has to be followed in the hospital, and there as well as same guidelines provided to the communities as well. So they have to follow the strict those isolation. Some of them is kind of law, and some of them is policies and procedures.
Okay, okay, thank you. I think the rest of the two questions you have answered while you're presenting.
Okay. Is that it? Okay, thank you for having me.
Thank you so much.
Hopefully this helps everyone just to give an idea of how the kind of one of the Western countries, how we are dealing with COVID, and as well as it's given idea. So, and it's kind of share our knowledge and share our support. And unfortunately, we are all in it together, and we all have to support each other. It doesn't matter where we are. We all have to support each other to come out of this.
Sir, thank you for your valuable presentation. You kept the virtual, every member of the audience hanging on every word what you have said. And I wholeheartedly appreciate for all the efforts you have made for the presentation, sir. You came on as for the request we have made, you came earlier and you have done your presentation. Thank you very much, sir.
Okay. Okay.
Thank you, Mr. Bhaskar. Thank you.
Take care. Enjoy the rest of the presentation. See you. I have to go. Thank you.
Have a great day. Thank you. Shall we have Dr. T. Sravanan back to us? Over to you, sir.
Really sorry about the technical hitch, and really thank Mr. Bhaskar for taking over my slot. Really moving on to the presentation of mine. Hopefully you all remember I was talking about the real ill-defined status of post-COVID. I'm just trying to highlight the important aspects what we are experiencing or understanding till this date, especially the few aspects of post-COVID. What I'm going to go through is my presentation. I'm going to go through the definition of whatever we understood till date, number one, of post-COVID or long COVID. and what is the incidence and prevalence and what are the clinical features. Especially, I'm going to highlight on the 4 aspects of clinical presentation of this problem, especially respiratory, neurological, fatigability, and psychosocial effects of this problem. So, as we all know that till date, everybody is able to access this information from WHO. One more thing I should admit, whatever my presentation is all taken from completely from standard international references, especially from WHO, CDC, and NHS. So it is not individual presentation of my own slides. Everything is taken from standard references. So this is a huge volume of problem, doesn't require specific explanation of this slide. Everybody is facing this problem of intensity of the COVID as it is. And if you see the clinical course of the COVID-19 to make us to understand the post-COVID status, what exactly the course of the illness behave to the community is going to be like the exposure, you get the mild to severe variety of problem. And usually the symptom starts 5 to 6 days after acquiring the virus or entering of the virus. And it may be lasting for 2 weeks, provided if it's going to be mild variety. Sometimes extended period, the patient is suffering in the form of so many clinical presentations. And once the patient recovers, probably we are in a position to see, or what we are trying to understand today is post-COVID status. So usually what we mean by post-COVID status is 4 to 6 weeks from the time of onset of the illness and from the time of recovery also. And that is, it may be a community home quarantine patient, it may be a hospitalized patient in the regular wards, or it may be a patient with intensive care also. So all the 3 categories of problem, very important, or bottom line, or very important to understand is all the 3 category of problem can experience the post-COVID status. That means it may be a mild, moderate, severe variety, all are going to experience post-COVID status. So what exactly this? It is basically the single lingering symptoms after the COVID, SARS-CoV-2 infection, and it is called as post-COVID, usually 4 to 6 weeks from the time of illness. So what are the problems we do come across in the post-COVID status? It's a wide range of the long-term symptoms are reported among others, and especially the understanding, as I was mentioning, it's very limited period, nearly 1.5 years. We try to learn whatever we are trying to hypothesize with this current illness based on the previous SARS infections. SARS and MERS infection, we try to, the sequelae of whatever happened, we try to hypothesize and we try to understand. These are all the anticipated problems. But really we are going to face the year later or 2 years later, that we have to wait and watch how it goes. But these are the common problems which we come across, starting from fatigability, the extreme fatigability, one of the commonest presentation of the post-COVID, and the loss of smell, even persistent cough, it can be lasting for nearly 2-3 months, and shortness of breath, the GI symptoms, cutaneous symptoms, forgetfulness and mental clouding or mental fogginess, then muscle pain and pins and needles and chest pain, headache. So a wide range of clinical presentation we do come across, of which the majority is going to be fatigability, loss of smell, shortness of breath, and to some extent which is not mentioned here, so forgetfulness and depression. This is a wide variety of system involvement in case of post-COVID, like cardiovascular, respiratory, dermatologic, neurologic, and psychiatric symptoms. That's what I was trying to highlight in the previous slide. And technologically improved status of the current scenario, we try to understand how much is the post-COVID status or conditions we come across. This is the slide which is taken from, I think, WHO, which is clearly mentioning about the social media monitoring of post-COVID condition. Nearly it's surging up like anything from the time of December 2020 to August 21, or maybe the current status of the post-COVID from the time of illness started in the August, the people who experienced they're going to come to us with a very much increasing trend of or increasing surge of post-COVID status. Okay. And why do these people develop? To be frank with you all, we have not understood completely the pathophysiology of COVID-19 infection as it is. There are a lot of hypotheses behind the development of clinical features of COVID infection, but the possible reasons behind this post-COVID status, it may be related to vascular inflammation, or it can be a cytokine storm, it can be vascular endothelial dysfunction, which predisposing to the clotting mechanism, or could be because of some neurotropism related to ACE2 receptors. There are so many mechanisms being attributed as a cause for acute infection as well as sequelae of COVID infection. What I meant by that is post-COVID status. So long COVID may overlap with the complications of acute 19 illness. COVID-19 illness is very difficult or hard to define. So it is basically long COVID is one category of disease. It is not only we come across in the practice, but also we come across like the post-intensive care syndrome, even the hospitalization related complications, and certain other conditions like multi-system inflammatory disorder. So wide range of clinical presentation we do come across a post-COVID. We do come across patients coming across with the vaccination-induced problem also, which I'm not going to discuss today. So it is a persistent severe fatigability, headaches and brain fog that is mild subjective cognitive impairment more than 4 weeks after acute illness may be independent of acute illness severity. It's very, very important definition at present available. It is subject to variations at the later date. After understanding the clinical profile of the patients, it might change. At present is the independent of acute illness severity mean it may be a patient managed as a home quarantine. It may be a patient managed in the regular wards or intensive care or intermediate care. The chances of coming across is wide range. Not only that, higher incidence. As per WHO, we are expecting surge in the number of occurrence of this post-COVID status. So the symptoms, if you see, nearly 3/4 of the patients they hospitalized with the COVID-19 and at least one ongoing symptom 6 months after their acute illness. It is basically studied from China, which is published in Lancet 2021. It's very clearly mentioned about nearly 3/4 of the patients by default they develop some sort of symptoms, of which, as I was mentioning, the fatigability or muscle weakness is the commonest symptom, followed by your dyspnea, sleeping difficulty, psychological disturbance, mood disturbance, and other symptoms whichever is enumerated here. Nearly 20% of the patients, 1 in 5 patients not requiring supplemental oxygen during hospitalization had decreased lung function after 6 months also. This is also noted. That means the slowly progressive lung involvement, even though the lung involvement was not florid or furious at the time of admission as well as at the time of discharge, as well as at the time of initial follow-up, but later date they can land up with requirement of oxygen therapy because of the damage to the lung parenchyma or airways. Nearly more than 1/4 of patients develop new neurological symptoms after their acute COVID-19 illness. So maybe it is studied from the France and in the form of fatigue or the muscle weakness, sensory disturbance, and so many other types of neurological symptoms, which includes headache, cognitive neurological disorders, problems with the taste or smell, whatever the problem which you are dealing with. The prolonged symptoms are common among the patients with mild or not recurring hospitalization. So nearly 35 to 54% of the patients with mild acute COVID infection had persistent symptoms even after 2 to 4 months. That's the reason the definition of the post-COVID is going to be irrespective of the primary illness intensity. They might land up nearly 3/4 of the patients, those who are landing up with the symptoms After 4 weeks of the acute illness, said to be post-COVID status, and it doesn't matter the patient is managed intensive care, intermediate care, regular ward, or home quarantine. It's a typical patient which I'm just trying to highlight here. It's a patient with 50 years old man admitted with hypoxemic respiratory failure. You can see the lung shadows here, high flow nasal cannula, and initial pulmonary function test or severe restriction of the diffusion impairment. And now the off oxygen follow-up computer tomography shows clearance of the infiltrates to some extent, the minimal fibrosis, but the patient continues to be is already off oxygen, clearance of the shadow, but ongoing dyspnea and fatigue, limiting the return to the work. So this type of presentation we do come across now. Maybe the patient, those who are admitted in the month of maybe January, December, November, October, September, all those, the last year end and the beginning of this year, now we started seeing the patients coming to us with the fatigability, tiredness, exertional dyspnea, but the imaging may not be able to show what all the intensity of the problem which you come across at the time of acute illness. It does mean that it has got its own characteristics of presentation, but unfortunately medical team of world all over the world try to understand what could be the reason, how to address this issue. The major issue is how to address. If you are not able to show any anatomical functional defect, when the complaints are huge and huge, naturally the question comes, how do we address? Is it going to be psychological? Unlikely, but it is not pure psychological. Then naturally we should always, the researchers are all in the pipeline to work on how to address these issues of post-COVID syndrome. That is a current scenario as far as the management of post-COVID status is concerned. So the diverse symptoms of the respiratory symptoms, I'm just taking you all through the respiratory problem as it is. The dyspnea is one of the commonest problem come across with respiratory, and the symptoms can be persistent nearly 87% of the population. And the potential persistent interstitial lung disease, there's a chances of organic lung fibrotic disease also possible, but it correlates with the deficits in the pulmonary function, maybe in the form of restriction, diffusion, impairment. And we're also able to show certain situations, the sustained inflammation through the acute and post-acute phase. And it is very difficult for us to enumerate the risk factors, but whatever we understand last 1 year or 1.5 years, the age, male gender, underlying comorbidities, especially obesity, smoking history, occupational hazard exposed patients, they're all prone to develop this problem of the post-COVID respiratory disorder. If you see this, the patterns emerging from the time of last year to till date, it may be a post-COVID pulmonary disease, persistent lung disease of interstitial nature, or persistent symptoms of the normal PFTs and thoracic imaging, other objective abnormalities like heavy diaphragm paralysis or pulmonary emboli. Even yesterday, two days back, we are admitted a patient with post-COVID nearly a month later, but continues to be dyspneic, and the lung shadows is not very much the scenario which I was trying to highlight here. But soon after the admission, the patient had sudden deterioration of the saturation, collapse, BP collapse. Finally, we could demonstrate pulmonary massive embolism and immediately thrombolized, patient intubated, all the resuscitation measures started. Now, nearly 48 hours later, patient is doing fine. So these type of scenarios. Another boy today, just now before coming to the presentation, I had a patient, 16 years old boy from Sirumugai who had COVID infection, 2.5 months. Since that time, is psychologically, emotionally is very bit of unstable. And number 2 is he feels always aches and pains. All over the body aches and pains. So how do we assess this? Really going to be of a big problem for the medical fraternity to understand, assess, and give a solution to the patient. Okay, it's a very 16 years old boy. This scenario is just telling you an example of the clinical picture which you are coming across nowadays. So the another scenario which I was talking about is respiratory symptoms. So the another symptom is fever, myalgia, headache, nausea, and the patient they started feeling better and discharged, but you have seen that the physical fatigability continues to be present. He started feeling tingling sensation throughout her body, but worst in the hands. So this type of different neurological symptoms other than the fatigability we do come across. The neurological symptoms wise, what is very important is the brain fog or the memory disturbance or mental thought block. So commonly come across nowadays. Maybe a week ago, another patient of a businessman, we treated this patient for post-COVID status, coming back to us with memory disturbance. Being a businessman, he's been moving from country to country. He claims that he is not in a position to remember what exactly the business dealing he is doing. So he started having some sort of assistant as well as some sort of notebook and other things to maintain his data so that it doesn't misled by the business dealing areas. So the brain fog is one of the most common neurological symptom. The short-term memory, concentration, word finding, speech difficulty, and sometimes we do come across muscle weakness. Other than the sensory symptoms, we do come across muscle weakness, and we do come across patient becoming more depressed also. That is psychological aspect. That is, you can see here more disturbance as well as sleep disturbance also. That bit of more panicky and don't get the adequate sleep and more amount of sleep, the poor quality of sleep they also started developing. Unfortunately, when you start working upon these patients, the imaging, the simple tool like blood investigations to look for any evidence of other reasons other than the COVID. When you do investigations like EEG, EMG, ENG, you may not be able to pick up exactly the reason for the current clinical picture. Here and there, sometimes you do pick up problem. Addressing those issues alone is not in a position to give a complete solution or relief to the patient. That means whatever we identified is only incidental finding, which is not real major the problem of the identified problem. Probably it is contributed by post-COVID status. Yeah, if you see the imaging also, you may not be able to see any major changes. Possibly we might come across the microvascular changes. The cognitive test, irrespective of the age of the patient, you might come across involvement. And elderly people, they're more prone for the progressive dementia status. Probably it's too early to say this statement. Probably a few years from the down the line, if you are able to follow all the elderly people with the post-COVID status, if you are able to convincingly get a data on this, that is a good statement. And other than the central nervous system, can also get peripheral nervous system as well as autonomic nervous system also involved in case of the post-COVID status. Small fibers as well as large fibers also involved in case of COVID status. This is what I was trying to highlight, the investigations to be done for neurological symptomatic patients to look for other than the COVID, any other reason like imaging, EMG, EEG, nerve conduction velocity study, as well as blood workup, identifying this problem, addressing this problem. Sometimes you don't get relief, meaning that we are putting the blame on the COVID as it is. So the symptomatic treatment of this neurological symptom, what we discussed is respiratory, followed by what we are discussing now is neurological symptoms, wide range of neurological symptoms. The brain fog, one of the important aspect of neurological symptom. But if you see this first statement on the brain fog, there is no specific treatment. So probably our understanding on this pathophysiology of consequences of this COVID infection, probably we may be in a better position to give them a solution for whatever the problem what you are facing to the patient so that they get better relief. So autonomic, small fiber, fatigability, these are all really conditions or the problems which is really to be addressed, but we are not in a position to completely give solution to these patients. So many neurological symptoms present in COVID patients correlate, important get broad history. The treatment is going to be supportive and symptomatic. It is very important, it is multidisciplinary approach to the post-COVID experience is critical. But we don't know, we should admit always that we don't know what is causing symptoms, but that doesn't mean this is not real. Reassurance, patients can get better. The fatigability, other important aspect of the COVID, post-COVID status. It's the most consistent, persistent symptoms people experience following COVID infection. Implications of unresolved fatigue is going to be physical, sensory, functional. That boy is whom I have discussed about is a polytechnic studying student. He said he's not able to sit and attend to the classes. He claims that when he goes to bed by 8 p.m., he's able to get up at 9 a.m., but still feels very fatigability. Probably he started developing this pleasure of sleeping and developing into laziness. We don't know how do we coin this. It is basically maybe a symptom of the disease, but since we have not understood the complete course as well as the pathophysiology, it's very difficult for us to give him a solution. So what I have provided today is supportive therapy to him and counseled him and thought of just watch how it goes. But the only problem here is more than a year or so, the person continues to be in a fatigue status, they can go into a status of called as chronic fatigue syndrome. So that we have to probably wait for some more time and see how these COVID patients, the post-COVID status, how they're progressing into CFS status, chronic fatigue syndrome. So it has got a physical, cognitive, and psychological and emotional component. It's very important. The chronic fatigue syndrome, it is not simple physical, but also cognitive and psychological emotional component also. So whatever the problems which I'm trying to discuss, it is not to be managed by a single person of the medical team, that is only doctors, no. It is basically multidisciplinary, different departments, but it is not only by the doctors, but also is very important play by role by the nurses as well as physiotherapists, rehabilitation unit, especially respiratory neurological rehabilitation unit. All these things are very important for the patients to feel that he started or he starts showing improvement from the post-COVID status. It is basically CFS going to be managed with reassurance and gentle activity within self-assessed limitation, rest and sleep, hydration, nutrition. It's very important. The psychological care, even it is attributed the psychological reason for fatigability, still we are not quite sure. And if you see these 3-4 slides which I'm going to project is taken from NHS, the UK, the NHS UK, which is very clearly projecting on this mood disturbances when the person is community admitted or home quarantine post-COVID, the 20 to 40%, anxiety is 30 to 50%, relationship difficulties 15 to 25%, sleep problems, adjustment disorders. If you see memory, concentration, huge variety of patients admitted in the home quarantine, not even hospitalized patient. This is regarding the hospital discharged patients. Almost similar number of patients experiencing depression, anxiety, and memory adjustment disorder. It's possible. Still, they are having some sort of statistics going on to have this, but still it is also reported. It is not only in the regular wards, but also ICU. If you see this, ICU admitted and follow patients 3 months, depression, anxiety, almost same, relationship difficulties, sleep problems, adjustment disorder, memory concentration, fear of COVID, so all the higher side. So meaning that the post-COVID psychological impact, as that I think that Jayasudha madam was mentioning in her introduction speech, very clearly the negative impact, the fearfulness is all huge, irrespective of after your infection, you manage in the home quarantine or in the ICU, regular wards or intermediate care, recovering oxygen or not recovering oxygen, the impact is very huge. Probably needs to have a lot of multidisciplinary approach, along with probably medications may be a little role, but the counseling, reassurance, staying with the patients, making them to understand the reality as it is, and making them to come out of this, what do you call that, the depression or anxiety status, so that they'll also mingle with the common people, those who are not acquired this infection. But it is not only that, this slide is very important. The healthcare frontline staff, they also experience anxiety and depression, insomnia, and fear of COVID. So naturally, they are also human beings. They also experience. These 4 slides I have taken from the NHS, really alarming numbers which we come across as far as the psychological aspect of the problem is concerned as a post-COVID. You can appreciate how much is impact it is producing in the clinical scenario. So what are the challenges we are going to face? We completed hopefully the second phase. We are in the anticipating and getting ready for the third phase. But there is a new disease with emerging evidence. Probably we need to understand the pathophysiology more and more so that we try to address the issues in a proper manner. And number 2 is uncertainty healthcare and society. And surveys across the country are patchy. And probably it is not going to be useful with the unidisciplinary pathways, but probably we need to go for multidisciplinary pathways. Then biopsychosocial approach also very important. This one is basically looking at the first phase. We are basically looking at the treatment, but the impact of, we face lot of impact of the resource restriction and urgent non-COVID conditions, post-ICU recovery phase, whereas the 4th wave and 3rd wave, we are going to face a lot of chronic conditions, including mental illness, psychic trauma, which will have definitely individual, family, economic injury. They're all expected to be. Probably if it's extending further and further into 5th wave, we are going to face this type of, the curve goes in this manner, that is continuous ongoing problem. So we should avoid, or we should make this cycle to be broken here by proper precautions, vaccination, social distancing. It's very important. Self-hygienicity, probably we can prevent this. This point also mentioned by Dr. Jayasudha in her introduction speech regarding the crowding in the common place started now. That was a basic reason for second wave, even though the government organizations are trying to project to the public, still the public is not having probably much of awareness that we are anticipating third wave if you don't, or if we don't follow the common precautions. Probably the medical team of doctors as well as staff nurse as well as all other team members of the paramedical staff should take an initiative to talk to the people, probably in our premises itself, probably to the community level, primary health center level or urban health center levels, to make them to realize that the chances of third wave, fourth wave, it might go on multiple waves. To avoid that, the simple measures can be followed in the form of the SMS, social distancing, maintaining the distance, as well as the self-hygienicity, as well as the what you call vaccination. So just come to the end of my presentation. The key points: the new or persistent symptoms more than lasting 4 to 6 months among the regardless of acute episode severity, and the symptom may present with fatigability, sleeping difficulties, depression, anxiety, and neurological dysfunction. Serial comprehensive reviews of systems and physical exams may better document possible long COVID manifestations and improve the management. But there is still a lot we don't understand, and empathy towards patients experiencing long COVID is fundamental. It's a very, very important aspect. Probably once you start understanding, the addressing issues also will be better. I think I come to my presentation. Yeah, thank you for allowing me to present, as well as share my understanding of this topic on post-COVID. Once again, I thank the College of Nursing Principal, Dr. Jayasudha Madam and Leena Madam for considering me for this presentation. And I also thank the co-speaker, Mr. Bhaskar, for taking over my slot. Thank you, one and all.
Thank you, sir. We have few queries.
Yeah.
Taking COVID vaccine 2 months after COVID recovery are common at present. This leads to what type of complication?
Okay. So COVID vaccine, irrespective of whether it's a vector-based vaccine or mRNA-based, only these two types of vaccines we do handle now. So whether it's a vector-based or mRNA-based, usually advised post-COVID infection 3 to 4 months. It is not 2 months, 3 to 4 months, number one. Whether you are taking the vaccine first time or post-COVID infection, the common problem of any vaccination is going to be neurological symptoms other than anaphylactic reactions. So we have come across, we are going to publish these two papers also. It's in the pipeline, so we are working on that. We come across a severe acute demyelinating polyradiculopathy. 2 patients, not COVID infected patients, they only received the vaccination, they developed a demyelinating polyradiculopathy. The same rule applicable for post-COVID 3 to 4 months later when they receive, there's a possibility of neurological deficits because of demyelination is possible. So commonly come across reactions.
Okay.
I hope I answered the question.
Yes, sir. Is it okay to go for vigorous exercises after COVID recovery for those who have no obvious symptoms?
But the vigorous exercise means its definition is entirely different from individual to individual. Usually the advised rehabilitation process for both lungs, the commonly involved structure, and the neuromuscular system, the second most commonly involved system, to go ahead with a slow pace, slowly step up, monitor your physical symptoms secondary to exercise, both respiratory as well as neuromuscular symptoms, then gradually build your exercise capacity so that the adaptation of the body system to the exercise is much, much better than to go aggressively on the exercise pattern. Usually it is not advisable to go for aggressive, but definitely it is to be slow and gradual pace.
Children at the age of 16 who become positive with mild symptoms, can they get reinfected?
No, whoever is, it doesn't matter whether it's a child or adult or adolescent. So there's a possibility of everybody, those who are infected is going to infect the others, transmit the infection to the others. So 16 years old also chances of spreading the infection to the others, other family members. The family members are immunocompromised. The 16-year-old boy maybe or girl may be asymptomatic or very, very mild symptom, but they can infect the family members of immunocompromised status, aged population, that becomes more serious illness for those population. So they are infected. They are infected.
Okay. Okay. Yes, sir.
Any other questions now?
No, sir. That's all.
That's all. Okay.
Sir, screen
Yeah.
share.
Yeah, I'll do that. Okay.
So this
Should I take it, madam? I need to go for the outpatient department.
Yes, sir. Yes, sir. Thank you so much.
Thank you.
This
Thank you.
lecture certainly benefited from your breadth of knowledge and the depth of your expertise. Giving it your time really helped us to make it possible, successful. Thank you once again, sir. Thank you for obliging and taking so much of time and effort in spite of your busy schedule. Thank you once again. Thank you.
Thank you, ma'am. Thank you.
Thank you. Very good afternoon, ma'am.
Good afternoon.
Very good afternoon. We are very happy and we are privileged to welcome you for our session. I know we are a bit late. Please bear with us, ma'am. Madam Dr. Kezia Vino, she's the president of Shanti Ashramam, International Center for Child and Public Health, Coimbatore. She received a medical degree from PSG MSR and completed a special training in pediatrics at Masonic Medical Center for Children, Coimbatore. She had a master's degree in public health from the School of Public Health, Harvard University, with a double major in child and international health. By education, she's a child health practitioner with a passion for public health, and for over 2 decades of experience. Her first assignment at Shanti Ashramam involved the formal integration of community health across all the service programs. Her focus on child health led to the scaling of the service footprint from 5,000 vulnerable children to nearly 70,000 across over 100 villages today. In 2017, she further established the International Center for Child and Public Health in Coimbatore. She's well known for collaborations with governments, Government of India, Tamil Nadu and Nagaland, multilateral institutions, UNICEF, UNDP, FAO, WHO and World Bank and so on, economic institutions, World Economic Forum, Switzerland, Confederation of Indian Industry, CII, and interfaith organizations, and that is Religions for Peace, Arigato International from Japan, Christ Vatican, Saudi Arabia, Austria and Spain. Served on the working committee for NGOs at the Planning Commission, NITI Aayog of Government of India, developed the child-friendly indicator for local panchayats with the Planning Commission of Government of India, part of the experts group that formulated the framework for health insurance for families living in poverty and the review of the state's routine immunization policy. She served as a lead consultant in 2004 for the very first Human Development Report for the state of Nagaland, India, commissioned by UNDP and Government of India, led the experts team at National Foundation of Communal Harmony in 2015 to review and strengthen Government of India's Project Assist program, collaborated extensively with the UNICEF India on multiple programs. She's received Leadership Award in Public Health Practice for her exceptional career accomplishments from the prestigious the Harvard T.H. Chan Alumni Association, Albert Schweitzer Award for Commitment to Public Health Practice. She's a recipient of Dr. Fan Shin Memorial Award for Innovation, and she's a Distinguished Alumni Award recipient of PSG institutions and Best Junior Medical Officer Award at Masonic, Dharma Chakra Award for the contribution of child health, an Outstanding Young Indian Award. And our CV goes on like that. Ma'am, we invite you to speak on shared responsibility of the society. Over to you, ma'am.
Thank you so much. Thank you so much for this. Thank you so much, Dr. Jayasudha and all the faculty at the PSG College of Nursing for these words of introduction. we've had wonderful presentations this afternoon. And I know you've already had two presentations from Dr. Sharavanan, who looked at long COVID and its complications. You also heard the earlier presentation on preparedness, how professionals can prepare. So I'm going to add the third piece to this conversation, and I know it's an hour plus, but if you're all patient, I won't take more than 15 minutes to look at the big picture. So what you've looked is at the professional, the individual, and then you've looked at, in a sense, the hospital setting and patients, and what are the experiences of patients. And like Dr. Sharavanan said, I think we don't know all about COVID yet, and therefore the openness of mind and the continuity of learning. What I'm going to do now is also to take you a little beyond the hospital and to look at it in terms of the community. I will promise to keep to my 20 minutes, and I hope you will have this sequence in your mind: the professional, the patient in a hospital setting, and people in a community setting. Devika, if you can help me with the screen sharing of the slides, please. Or if it is from PSG itself, where would you like this, the slides to be shared? Devika, can you hear me? Can you come online and tell me if you're sharing? Dr. Leena, do you have the slides to share? Devika, can you please request for the screen sharing? Help from the PSG college, from the admin of the PSG nursing.
Ma'am, we don't have actually slides, ma'am. We are making her to be co-host. Welcome. She is in the name of welcome. So we are making it her as a co-host.
Devika, have you got it?
She should be, ma'am.
Okay.
Co-host.
No, Devika, you will have to unmute yourself, Kuti, otherwise we'll keep on delaying the presentation. Edhila irukken sollukana?
Ma'am. Good afternoon, ma'am.
Screen share pannukane?
Ma'am, screen share options.
You can share it, ma'am.
Yeah. Ipo okay, ma'am.
Pannir Kuti. Thank you. Thank you. Always when technology comes, we need a second, but I hope this will be okay. Wonderful. So I think as you see on the screen, the topic that I've given to us is public health outreach in the midst of COVID-19. You can't speak of responsibility without understanding the context, and I'm grateful to PSG College of Nursing for convening us in the midst of the pandemic. Next slide. Now, this is something that I want to bring to your notice. I think so many of us, our lives have changed and changed significantly. I mean, this typically would have been a lovely meeting at the campus of PSG College of Nursing, but we've logged in almost 200 of us from around the world. Similarly, I think, as this cartoon shows, I think, the priority in people's lives have also changed, and sometimes for the better. I think this pandemic has presented to people around the world the importance of health and why it's so important to also think of public health. Next slide. Now, this is for all of you students and faculty, just an update. You will see that almost 190 million people, this is today's data from the dashboard, 190 people have tested positive. And you will also see that India has an important share of the total burden of disease, which is the total number of people in the world who have tested positive to the coronavirus. India, in fact, is in the top 5 and has been consistently in the top 5 countries as far as the number of people affected by corona is concerned. Next slide. Now, this is an important data. Dr. Sharavanan showed you the experiences of individual patients, as well as Dr. Sharavanan told you in a group of patients what the data was showing. For all of you students who are here, if you look at on the x-axis, the graph starts in March 2020. This is when the lockdown happened in India, the first lockdown, and we had the first wave. And if you look on the y-axis, it is the number of cases. And you will see that the peak of the first wave was nothing compared to the peak of the second wave, where all of you nurses and doctors and everybody in the healthcare sector was very busy. So I'm sure Dr. Jayasudha will be able to present to you these data again as to how severe the second wave was. We touched up to 350,000 patients. And at the moment, as of July 19th, which is yesterday, we're still on the downward slope, but we have not hit the baseline. So for all of us healthcare professionals, data is important. We're not yet at base level. And like Dr. Sharavanan said, third wave, fourth wave, we don't know what it is, what kind of peaks we are going to see, but we know the important things that we have to do so that we are better prepared to meet the next wave. So just the comparison of the caseload between the first wave and the second wave for you. Next slide. So what I want to do quickly in the next 20 minutes is to share with you some data. I don't want to be only speaking about COVID, because shared responsibility in healthcare is about looking back and looking ahead. I want us to revisit what is health, even when COVID is dominating all our caseloads. I want us to see its impact and the core of my presentation today. What is it that we can say is a shared responsibility for healthcare providers, the physicians, nurses, nurse practitioners, everybody involved in the healthcare sector? What is shared responsibility? I do want to go back to my inspiration, Mahatma Gandhi, and what Gandhiji had to say about it. And then as we speak of long COVID, I think we should also not forget to look at a post-COVID situation. Next slide. Now, this is a very important data. It's pre-COVID, and it shows in India's population what has been the transition when it comes to birth statistics. And you will see India will turn 75, 1947. We got independence, and on August 15th, India as a nation will be 75 years old. We still have mortality. It's much better than what it was many years ago, but mortality still happens. We are in the midst of an epidemiological transition, and we now have in India what is called a double burden, meaning we have infectious disease and we have non-communicable disease. And COVID has shown the intersection or the interaction between both the infectious and the non-communicable disease. Next slide. So again, infant mortality, we have done well. Again, on the you have the numbers on the y-axis and dates and years on the x-axis. When my mother had me many years ago, the mortality was very high. Today, if any of you nursing students are accompanying a young mother in labor, you will know that it is survival rather than death, which is the first experience of many, many children. Next slide. It's very important for us, therefore, even in the midst of the COVID pandemic, to look at health in a time frame, pre-COVID, during COVID, and post-COVID, so that we know the broad picture of health in a sense. Next slide. Now, this is something that I want to introduce. You don't have to go into the slides in detail, but this is what Government of India is now doing for 3 years. And as students of nursing, I want you to know that for the first time in India, we are ranking states based on their performance, based on health outcomes, based on how we manage health systems, based on key process inputs. And you will remember Kerala has stood first all the 3 years. Tamil Nadu used to be number 2 on the ranking of states, and we have slipped into number 3. Now, so understanding the big picture of our practice and our studying is very, very important. And you will see there is a correlation between this and the way that states have been able to deal with the second wave and the first wave of corona. Next slide. So I encourage all of you to look at this wonderful report and the ways that states in India have been ranked is, next slide. They have been ranked is neonatal mortality, under 5 mortality, total fertility rate. For example, for the first time in India, fertility rate, meaning if a husband and a wife are married and they are in the reproductive age group, the number of children they have in India now is about little above 2. But in states like Kerala, Tamil Nadu, and Karnataka, it's 1.5, 1.6. So again, it's a shrinking family. Therefore, sometimes in times of COVID and other things, we also have caregiving burden. And in families under home quarantine, we saw where there were elders, there were people with mental health illnesses, there were people with disabilities, the burden also went up. So this is a document that I want to introduce to you, the faculty at the college, as well as the students, so that you can from time to time also look at the big picture. Next slide. Now, again, as I said, in the comparison, there are different ways of clustering the states in India. Larger states, smaller states, union territories. Tamil Nadu will typically come under the larger states. Next slide. Now, it's very important for us to remember that we are not the only people influencing health. If you remember your classes in community medicine, you will know that your professor told you there are socio-economic determinants of health. So whether you're a man or a woman, whether you're born to a family with literacy or no literacy, whether you're born to a family that has good access to health services. So social determinants of health are there, economic determinants of health, individual income. So during COVID, we saw even healthcare professionals, middle class families, upper middle class families, this crisis completely overwhelmed us. But we have to look at investment also at a country level. And here you will see India is doing extremely poorly. And therefore, I feel one of the reasons that our general health status is poor is because we don't invest in health. I work with children, as I was introduced. Pediatrics and child health is my area of interest. And we have seen during this pandemic that the investment of the country has been less than 1%. What does it mean for you nurses? If you have 100 rupees, the country is spending only 1 rupee on a child. Do you think we can take care of children with such poor investments? Neither at the private level nor at the government level. Low investments will help us. We need enough money so that health systems are strong, preventive health services are better, nutrition is taken. So remember this socio-economic determinants of health, and there again the shared responsibility comes. We cannot just take status quo. Today, if a girl is undernourished and not taken care, government gives a noon meal scheme in the government. That is shared responsibility. Today, if there is a student who can't pay her fees, institutions like PSG help them with scholarships. That is also shared responsibility. So this is a slide that summarizes socio-economic determinants of health. Next slide. Now, I want you to remember, many of you are students of PSG Institute of Medical Sciences and Research. While our primary identity is of a hospital, we came out of the goodwill of people. We are a non-governmental organization. PSG is a trust. And in India, this idea of taking care of people goes back to the 19th century and the 20th century. And it is built on 2 very important values of Indian culture: dana or giving, and seva or service. Even in modern medicine, whether you are a physician, whether you're a physiotherapist, whether you're a nursing, what do you give? You give your professional skills. What do you give? As Dr. Sharavanan said, you have to give empathy. So both the tangible and the intangible. And remember, ours is a service sector. We give professional services, but as nurses and physicians, service has to be of the highest quality. I remember a wonderful saint from Italy, St. Francis of Assisi, who says, it is in giving itself that we are true servants of God. So it is not just doing the temperature and the blood pressure and the injections, but when we give our kindness and our empathy, that is there. So I want you to remember that this culture of India has these two pillars, dana and seva, as central aspects. Next slide. Now, having said this, I also want you to know that the government is still the predominant sector. All of us, whether it is PSG or Masonic or the Center for Child and Public Health, we are important drops in the ocean, and we should not forget that. But we are only drops in the ocean. We have to call for government to do better and better and better and better. In some states, you see data here that sectors like the private sector, health, the religious organizations are doing their bit, but we need much more if we are to deal with the overall needs of 1 billion people and plus. Next slide. Now, this is where I'm going to spend about 2 or 3 minutes about shared responsibility. Responsibility is not just what your head of the department says or your matron says. You are a professional, take care of the patients. Or your professor says, you are a nursing professional or a physician, and so you must learn responsibility. Responsibility is being responsible for everybody. And I'm sure in your community medicine classes, you will be hearing about this idea of sustainable development goals. These are the UN's goals, and you will see that there are 17 sustainable goals. Let me take one example. The second goal, there is a nice picture there. It's zero hunger. You look at 4, it's about education. You look at you look at the first one, which is no poverty. None of this we can do alone. So shared responsibility is about large goals that make this world a better place. It has concrete ways of doing it, but it requires people to come together. In this COVID-19 pandemic, even simple things, countries were caught unawares. PPE kits, masks, vaccines. Vaccines are produced only in a few countries of the world, but it's our responsibility as healthcare providers that every human being who is eligible should receive the vaccine. Now, just to put a little statistic to this, Dr. Sharavanan was speaking about the impact of the vaccine on an individual person where demyelination is possible. It's a rare, very rare complication, but it does happen. Look at the larger responsibility. The world has 7 billion people, of which 2 billion are children. As of now, only few countries are vaccinating children. So there are about 5 billion, almost 5 billion people, adults, which means we need a similar load of vaccines too per people. But as of today, 2 billion vaccines have been given around the world. Dr. Soumya Swaminathan, the chief scientist, in a meeting last week told me 75% of these 2 billion vaccines are just in 10 countries. There are 200 countries in the world. You know the data that I gave you about how many people tested positive? It is from 200 countries, but only 10 countries have got 75% of the vaccines. Is this fair? Will we come out of the pandemic quickly if we have such skewed presentations? So just like socioeconomic determinants of health, one of the things why we speak about shared responsibility is because the world is unequal. And therefore, one of the primary goals of the healthcare sector is health equity. Immaterial of whether you're a man or a woman, rich or poor, young or old, everybody must have access to good and appropriate healthcare. And we know this will only be done if all of us remember that every response in health will require our coming together. So this is an image of shared responsibility. And we know During the pandemic, I want all of you young nurses to know this will be the first time, I work with children in early childhood as well. Early childhood, I'm sure you would have had classes in pediatrics, the first 1,000 days of life where there is brain growth and massive neurological development and developmental milestones. Imagine for a child who is in the first 1,000 days. We are now in about 480 days into the pandemic. 50% of their early childhood, of their first 1,000 days has been robbed. And one of my work with the state government has been to see how can we take care of children. A scarred childhood is a scarred adulthood. Just like Dr. Sharavanan told you about long COVID, about fatigability, about psychological problems, imagine a whole generation of children who are having a compromised start to life. So all of you who are in preventive pediatrics, who are in community medicine, we have a large role to play as the pandemic fans out. Next slide. So this is the heart of my presentation. If you take the word responsibility, shared responsibility, I would like to break it down into two parts. Response. Anytime we see a sick person, we see somebody in the emergency, we see somebody who's eligible for the COVID-19 vaccine, we see an elder who has angina, or we see a child who is eligible for vaccination, we know our intention is there. As healthcare providers, nurses, doctors, all of us, we know what to do. We want to do something. Motivation, rationale, intent. And I think that is one reason why we are having this seminar, that we should never forget that we have this professional training to feel the need for response. But sometimes there is a gap between what we want to do and what we actually do. And here is where shared responsibility calls for preparation, both as professionals, but also for cooperation as teamwork. So remember, breaking down responsibility into response and ability. This seminar, Dr. Sharavanan spoke about empathy, to be kind. As nurses, we all know, not just giving a good injection or starting an IV line. Kindness is the first thing in a prescription for a patient. But remember that kindness will only be good if we have the ability. We need skills. We need new skills. We need to keep refreshing our skills so that we are also a good professional. We need knowledge, updated knowledge. Almost every week, as far as COVID is concerned, dynamic knowledge. There's new knowledge coming in. When is the first dose? When is the second dose? When is the booster dose there? And remember also to look at people who have accrued experience, not just hospital-centered experience. We need experience from the lab. We need experience from the patients. We need, for example, in COVID, I'm just writing a paper about 100 families who were under home quarantine. Lots of new things. Besides all of this, there are lots of new things that we're able to do. And then not to stop at just that, to look at the community setting. So for all of you young people, young professionals who are listening, you must pay attention to both your motivation, your intention, and your rationale, so that you become better professionals, positive professionals, engaged professionals. But remember, you must also keep adding your skill sets so that your response is of high quality. Next slide. And therefore, I say, is there an in the middle of the pandemic, can we speak of a healthier India? I think this seminar is not only about this mass catastrophe. In fact, the WHO Director General, Dr. Tedros, says this is a year without a precedent. We've never seen a year like this. 200 countries, a pandemic, movement stopped, people got affected, schools were closed. In modern history, schools have never been closed for so long. All of this we never thought would happen, but has happened. But even in the midst of this, as healthcare providers, we cannot stop with the diagnosis of anxiety or depression. We have to go beyond. We have to see how can we build resilient societies? How can we visualize something better? How can we have more beds in the hospital? How can we have more oxygen preparedness? How can we look at people and have much better controlled non-communicable disease? 3 slides and I will be done. Next slide. And I want you to think about it. What are the lessons? What are the lessons from this COVID pandemic? And this points to shared response. We need a policy that vaccination is good for all. vaccination for all. It seems very simple, but this policy then pushes the government to get everything for everybody. We need research. You have to keep looking at data and experience and going forward. We also need people who do good work. I have worked with children and HIV now for 21 years. In 21 years, we still don't have a vaccine for HIV. It's also an infectious disease. It is also caused by the human immunodeficiency virus. But look at this, scientists around the world work together and we have a vaccine now, just within 1.5 years that we're able to give. We need to do good practice. We have to keep learning from our practice. We have to see what works and what doesn't work. I think that is why it's so important to have this link between theory and practice. We have to have everybody's contribution. Like when the lockdown happened, one example for you, at ICPH and Shanti Ashram, we have families with HIV. And for them, you know, for patients with HIV, you have to give the antiretroviral every day at the same time. The sudden lockdown meant people did not have access to viruses. So the immunity came down, they were more susceptible, and they picked up the virus. So we need everybody's. And remember, health is not just a doctor's role or a nurse's role. We must go beyond hospitals. We have to say health is the building block. Again, to quote Dr. Soumya Swaminathan, who said, health today has become the center of functioning. No health, no business. No health, no university. No health, no school. So I think for all of us, one of the challenges, one of our responsibilities is to speak about health in a much more broader way and not just as a disease cure or a disease prevention framework. Next slide. Also, I think as young doctors, as young nurses, we have to speak about health, not just in the language that we speak. We have to get common language. Podu makkal kitta Tamil, English, Hindi, Bengali, eppadi eduthu solla mudiyum. We have to learn local language and good communication skills. We have to work together. Remember, not just the teamwork in a hospital, teamwork with every sector, socio-economic determinants, work with people who can make it better for families to be healthy, to strengthen health systems, not just tertiary care. We know when I was training in Masonic Medical Center, for every 100 children who came to the OP, only 10% to 15% required inpatient care. 85 came to the OP, saw a doctor and went back home. And yet we have not reinvented primary healthcare better and better. How do we speak? How do we speak of nutrition? How can we speak of mental health counseling? All of these health system strengthening has to be there. Remember what I told you, only 1 to 2% is spent on health. In fact, one joke is when in a public meeting, I said, how many of you take care of your health? Everybody raised their hand. And I said, what do you do? They said, insurance. That is not investment in health. Investment in health is exercise. Investment in health is vaccination. Investment in health is micronutrients. Investment in health is master health checkups. Investment in health is better mental health. And behavior modification. While we think that little things can change, this COVID pandemic, Dr. Srinivas, Dr. Sharavanan and everybody, we all rely on behavior, masking, physical distancing, hand washing. And yet we don't spend time enough to be able to understand why people do what they do. Why is it so difficult to wear the mask? Why is it so difficult to wash your hands? Because we have to work with the human brain, but also with the human capacity. Next slide. So I want to end with two things before I come to the quote. What I have done for you today is I've looked at the progress we have made in India over the last 75 years, and health has been a very important part. In 1947, if a child was born, the child used to live only for 32 years. Today, 64, 65, doubling of life expectancy. But the COVID pandemic has shown us that it is not enough to do these small changes. We have to improve health behavior. We have to make health a priority. We have to invest in health systems. And we as healthcare professionals have to believe that preventive health, promotive health is very important. Sometimes even us, we look down at preventive health and promotive health. And we know that preventive and promotive health are far superior investments in health than hospital care. When we get unwell, we want to get well, but we must remember there is a window to always stay well. as young professionals, remember, responsibility is important. You must have the intention to respond. Kindness, empathy, all of that should be top on your prescription. But you must also continue to learn new skills, acquire new knowledge, and practice every day so that you can be better professionals. But don't forget, for big problems, you need to work in teams, not just in hospitals, but across the world, so that social economic determinants of health can be impacted. And may I end with the wise words of someone who I like very much, George Bernard Shaw. He said, "We are made wise not by the recollection of our past, but by the responsibility for our future." This is what Mahatma Gandhi said. When you care for the other person, a patient or not a patient, you actually care for yourself, because you're using your skills and you're using your humanity for something that is bigger, greater, and I think something that moves your heart very much. So thank you, Dr. Jayesuda, and I hope you will take out of this presentation also the message that health for all is still important in the middle of the COVID-19 pandemic. Thank you very much indeed. Thank you, Dr. Jayesuda.
Thank you so much, ma'am. Really, the seminar was so wonderful. Like, we gained a lot of knowledge, and where you have made us to feel that the responsibility of every one of us in our society to make everyone to be healthy. So that's the thing. Thank you so much, ma'am.
Thank you very much. Thank you.
This is the end of our session. I take this opportunity to thank all the speakers of the sessions, Dr. Saravanan, Mr. Bhaskaran, and Dr. Ketsi Vinovaram. Even there is often a spike of technical issues we could able to manage. And thank you for Mr. Bhaskaran to go for the first lot and made the time being. And I thank our beloved principal, Dr. Jayesuda, for providing this opportunity and make it possible. I thank Professor Leena, program coordinator, for motivating and for untiring work behind all workforce in this webinar. Warm gratitude to the department faculty for the contribution of this webinar. I thank the non-teaching faculty for their timely help. Last but not the least, I thank all the individual delegates who patiently being over here till this end of this session. And thank you very much for everyone over here. Thank you.
Thank you. Thank you very much.
Thank you so much, ma'am.
Thank you, Jayesuda.
Thank you, ma'am.
Thanks,
for being
Leena,
with
and
us.
thank you for the moderators. Thank you. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Dear delegates, the feedback link is given in the chat box, and as well in your invitations where you have received as WhatsApp message. Kindly do